Good evening, everyone. Welcome to our back pain webinar seminar. My name is Elise Hillscamp, and on behalf of Premier Physician Network and Premier Health Spine, I would like to thank each of you for attending this evening. We're very glad to have you with us. Tonight, we're here to discuss back pain. As you may know, it's a very common issue for many, and so you are not alone. The good news is that there are options available to help you reduce your pain and increase your mobility and get you back to the activities that you love. Our panelists will give you a brief presentation this evening on those options, and they will also answer some of your questions following their presentation. Just so you know, we will accept questions throughout the entire presentation this evening, but we'll wait until the end to start to pose them to the panelists. So if you would like to submit a question at any point throughout the evening, there's a Q&A button that will appear if you hover your cursor over the bottom of the Zoom screen. It's kind of where you see mute and chat and everything like that. There's a Q&A button. You can send those at any time. You can just type them right in there and we will get to as many of them as we can tonight. Please disregard the chat message. We will be using pretty much just the Q&A portion box, if you will, to answer those questions. Also, this seminar will be recorded. You will receive a link to the recording via email in the next few days should you want to go back and reference any portion of this evening's presentation. So let's start off the evening by taking a moment to introduce our panelists. Sujit Bimareddy is a spine surgeon at the Clinical Neuroscience Institute. He is a graduate of St. Louis University Medical School, and he did his neurosurgery residency at the University of Illinois College of Medicine at Peoria, where he also completed his neurosurgery spine fellowship. Daniel Quinones is a spine surgeon at Premier Orthopedics. He is a graduate of Jefferson Medical College of Thomas Jefferson University in Philadelphia. He did his orthopedic surgery residency at University Hospitals Cleveland Medical Center. Additionally, he completed his spine surgery fellowship from Washington University School of Medicine, Barnes Jewish Hospital in St. Louis. Dr. Bimareddy and Dr. Quinones practice at Premier Physician Network. They are also part of the Premier Health Spine team. Premier Health Spine takes the pain out of finding a back and neck specialist. With one phone call, you'll be connected to the right specialist for you. From our team of orthopedic surgeons, neurosurgeons, pain management specialists, and physical medicine and rehabilitation specialists. So with that, let's get started on this evening's presentation.
Good evening, everybody. Hey, I'm Dan Quinones. I'm one of the orthopedic spine surgeons here at Premier. And joining me today, Dr. Sujit Bimareddy with neurosurgery. Both of us work together. We're both spine surgeons with different training backgrounds. And so we each have unique takes on what we're talking about today, which is back pain. And it's an incredibly common problem and one that we often see patients for. And Dr. Sujit, you want to introduce yourself?
Yeah, hi, Sujit Bimareddy. I just joined Premier last year, and my background is from a neurosurgery standpoint. There's first, one of the common questions we get asked is, what's the difference between an orthopedic spine surgeon versus a neurosurgeon? Ultimately, when you go to see a spine surgeon, whether they're from an orthopedic spine surgery or a neurosurgery background, they're ultimately a spine surgeon. So there are a lot of similarities. Our training usually is a little bit different. So Dr. Quinones, as you guys heard, did residency in orthopedic surgery and then did a fellowship specializing in spine. As a neurosurgeon, I did a 7-year residency and combined with the fellowship in my last year, dedicated to spine work. We ultimately treat very similar pathologies. I think as a neurosurgeon, the one area that we treat that orthopedic spine specialists do not is, spinal cord tumors themselves. So Dr. Quinones, and other orthopedic spine surgeons will treat spinal column, like vertebral body tumors, but the spinal cord tumors themselves, usually a neurosurgeon will treat those.
Yeah, so we'll go ahead and get started on our talk about back pain. Elise, if you could advance the slide, please. So back pain is extremely common, and I don't know if you guys can see how many people are on this webinar right now, but it could be at least 100. I heard 100 registered. It's extremely common. It's extremely relevant. Everybody knows someone who has had back pain in their life, even minor, all the way to major, missing work, needing treatment, and so 80% of the population has back pain, low back pain at some point in their life. And because it's so common, it costs a lot of money to the government and to insurance. It is a significant expense for the medical system. And so we'll talk about some ways to try and prevent low back pain, but as well as treat it and how to prevent it from coming back. So it's actually the second most common cause to visit a doctor's office. It's certainly the number one cause people come to see me or any spine surgeon is typically low back pain. In almost a quarter of, if you asked 4 people on the street if you've had back pain in the last 3 months, at least one of them will say yes. So it is extremely common. Elise, next slide, please. It is, even though it is so common, fortunately, it is actually quite usually short-lived. We say the odds are in your favor that you're going to get better, even without treatment, although that includes with treatment. 60% of patients with low back pain get better in the first few weeks. I know this is probably most common of, aches and pains in the low back, maybe some heavy lifting, sore back, bad night in the tough night sleeping, you wake up with a sore back. The vast majority of patients are better in the first couple weeks. And then almost all patients, more than 90% of patients, get better within 3 months. And so although it may seem like the end of the world, because you're suffering so strongly because of the back pain, just kind of take hope that it's going to get better. The vast majority of patients are better within 3 months. And the scary the scary causes of back pain, things like cancer, infections, trauma, fractures, those are extremely rare when you consider all causes of low back pain. Less than 1% is the scary things. So take heart that you're going to get better, and within 3 months most often. Elise, next slide, please.
So, with all those causes and how common back pain is, you might be wondering when you should seek help. So since most back pain improves within 1 to 3 weeks, if your pain persists past that point, after you've tried some kind of taking it easy, resting a little bit, and you're still continuing to have back pain, that might be a sign that you can start calling your family doctor first, see what options there are. If you start to notice any neurological symptoms, such as weakness, numbness, or tingling in your legs, like a Charlie horse going down your legs. A lot of people are familiar with the sciatic type of pain that starts in your back and goes down your leg. Those are, if that is happening, then definitely talk to a doctor. Especially weakness, you don't want to, if you feel like you're weak or you're falling because of it, you don't want to wait too long. So recommend talking to your doctor about that. If you have any unexplained weight loss, so as Dr. Quinones mentioned earlier, the the more serious causes of back pain, such as cancer, are extremely rare. However, cancer can be accompanied by unexplained weight loss as well. So if you notice that, then accompanying back pain, then talk to your doctor. Another cause of neurological symptoms is having bowel or bladder problems. So if you're incontinent, there are a lot of people that can have dribbling at baseline, but if there is something that's abnormal to what you normally have, that's a sign that you need to talk to your doctor. If you have any back pain that has association with fever, that could be a sign that there is an infection at least starting or going on in your back. Or if your back pain is after a fall or an injury, even if it is a minor injury, and you're having severe back pain, then that needs to be evaluated to make sure there isn't anything unstable, like a fracture or anything like that, causing your back pain. Next slide, please. There are some red flags, meaning whether you notice these things or whether when you talk to your family doctor, they know some history of you. These are very important and needs to be evaluated as soon as possible. The first thing is with infection. So if you have a history of fevers or chills and you're having severe low back pain, and particularly if you have a history of IV drug use, or if you're a current IV drug user, it's very important to be evaluated promptly, so that the appropriate treatment with antibiotics can be started and to mitigate any neurological consequences down the road. So if you have a history of cancer and you start to have severe back pain, then it could have spread to the bones in your spine, and that could be the cause of the back pain. If you're in trauma, if you're enrolled in a car accident or a fall, there are a lot of people that develop neck pain after run-of-the-mill accidents, small accidents, to bigger car accidents where people are walking around but they have significant back pain. So it could just be a muscle strain, or it's causing the back pain. It's very important to follow up on that. And then lastly, Hara-Kawano syndrome. This happens when there is something pressing on the nerves within your lumbar spine, and you might notice weakness in your legs, and also you could have bowel and bladder incontinence, where you are peeing on yourself and you don't know that this happened. So that is a very big red flag that you need to be evaluated promptly in the emergency department. Next slide, please.
So with back pains being so common, it's pretty obvious that there are probably a lot of risk factors for back pain. There are a lot of reasons to get back pain, and people who are at highest risk for pretty symptomatic back pain and needing to seek treatment, there are some risk factors, and so one of them being any kind of mental health disorder like depression or anxiety. It's not physically that those patients are at higher risk for back pain, but their perception of that back pain is distorted by the excessive levels of anxiety or depression that they have. So let's say I hit my thumb with a hammer, I'm going to say, ouch, that hurt. But someone who has high levels of anxiety, they hit their finger with a hammer and they say, ouch, that hurt. I'm going to bruise, my thumb's going to fall off, I'm going to lose my job, I'm going to be homeless. And so it kind of snowballs. And so patients with high anxiety or depression, their perception of back pain is different. And so they may have severe back pain that needs to be evaluated. back pain can run in families too. There are medical conditions that have a genetic predisposition. So people with a family history of osteoarthritis, there's a genetic component to the wear and tear arthritis, inflammatory arthritis like rheumatoid arthritis or psoriatic arthritis. Those all kind of run in families, and so those patients with a family history can also be at risk for low back pain. Patients who have structural problems with their spine, people with scoliosis, malalignment, flat back syndrome, people with structural problems are at risk for low back pain. Patients who have certain occupations or perform activities can be high risk for low back pain. I'm a spine surgeon. I stand bent over a table for 10 to 12 hours a day. So I get back pain, all the time. Truck drivers, all the bouncing around on the road, people who operate a jackhammer or a forklift, or working in a factory, doing repetitive motions, picking things up all the time, putting them down. Patients with those types of occupations are at a higher risk for having low back pain. Patients who smoke or use tobacco products, the nicotine can actually heighten your sensitivity to pain, and so those patients are at risk for back pain as well. People who just sit around and don't do much. I think of the movie WALL-E and all the people sitting around in the chairs who have lost all their muscle mass. You're at risk for back pain if you have weak muscles or you live a very sedentary lifestyle. If you're overweight, that just makes sense, right? You're putting more pressure on your joints, you're putting more pressure on your discs, you're forcing your muscles to work harder to hold yourself upright. So being overweight can have a significant contribution to low back pain. Patients who are older, anybody, it's a spectrum. The older you get, the more degenerative changes you accumulate. The weaker your muscles get, potentially, the weaker your bones get. So as you age, you're at higher risk for low back pain. And then gender. Men have more low back pain than women, and if you ask my wife, she'd say it's because men are weaker. But for whatever reason, men tend to have more low back pain. Next slide, Elise. So what are the symptoms, right? So it's easy to say low back pain, but there are some nuances to the pain and that we want you to tell us about when we're evaluating you, because they can kind of clue us in to help us diagnose the source of your low back pain. So some patients, you might feel clicks or pops. Those can be the arthritic surfaces of the joints. So the cartilage joints in your spine, if they're not smooth because they've got some degenerative changes, rubbing together can make noises. And so you might hear some clicks or pops. The other symptoms, stiffness is a big one. Patients can have trouble getting up from a chair and standing up straight. They feel super stiff in the morning when they're getting up. So stiffness, that plays a role into postural problems. There are some patients, it's not the muscular stiffness that keeps them from being able to stand up straight. Some patients actually have structural problems where their discs have kind of eroded in the front of the spine, and so their spine pitches them forward, and so they can have trouble standing up straight. Patients complain of muscle spasm or knots, right? They feel a knot in their low back, which is a spasm of the muscle, and that can be very painful right at the site of the spasm. Or it can be dull and achy. Patients are like it starts in the middle of the low back, but it spreads out, or it spreads up the muscles of the spine. So it can be just a dull ache even, that's kind of diffusely that you can't really pinpoint. And then also some patients have low back pain, but then that pain travels down their leg. And typically that's because of a pinched nerve in the lumbar spine. where it triggers back pain, but also leg pain. And then some patients, the pain comes and goes. Maybe it's only in the morning, and then they walk around and loosen up and the pain goes away, or only at night because they've been working all day long and they finally have a chance to breathe and they realize their back hurts. So it can be constant or it can be intermittent. And then positions can play a role too. Some patients, it hurts when they bend forward, where they feel like their back is locking up and they struggle to bend forward. And some patients actually feel better when they bend forward. They feel like a pressure is released when they bend forward. Oftentimes leaning back or hyperextension of the back, reaching up in the cabinets, that can cause some pain in the back too, because you're loading the joints of the back of the spine. So certain positions can make your pain better or worse. Next slide.
So what are the some of the causes of back pain? This is a drawing of a spinal column all the way from C1, which is the first bone in the spine, down to your sacrum and coccyx. The coccyx is the end of the spine, and the sacrum connects into the pelvic bones and forms the foundation of the entire spine and allows us to stand up. So one thing I want you guys to notice in this picture is all these bones, they have at least 4 joints each. So there are a lot of different bones and a lot of joints that can contribute to the back pain. So we'll talk a little bit more in depth. Can we go to the next slide, please? So the first one is spinal arthritis. Just like you might develop arthritis in your knees, hands, anywhere there's a joint that is used repeatedly. You can develop arthritic changes as we get older. And in this cartoon, you'll notice that the normal joint in the top section or in the top circle, and then kind of angry, inflamed joint in the bottom circle. And that's a normal progression of everybody's spine as we get older. And as these changes accumulate, they can contribute to back pain. Now, can we go back to the previous slide, please? So each one of these joints can develop those arthritic changes, and also in the front where there are discs, you can develop arthritic changes there too. So as you can see, we have only one joint in each knee on each side, but we have multiple joints in the spine, so they can rapidly accumulate and be a cause for back pain. Next slide, please. The slide after this. Okay, next, click again. Okay, so bulging disc. So the discs are cushions between each of the bones. So as we stand and we put all the stress on our spine, the discs relieve some of the stress that's being transferred to the joints and to the bones. And normally the discs have water in them. They're kind of like spongy matrix that just like a jelly that just kind of gets crushed, and then it can regain its shape again. But with time, a lot of people will develop bulging discs that can eventually press on a nerve that can cause back pain or pain shooting down the leg called sciatic pain. Next point. So as the discs lose the water content, they can become small also, and they lose their height. As you can see, the point that says the degenerative disc, which is the disc becomes smaller and smaller, and eventually you could have a situation where there is basically bone-on-bone contact, and then that can cause a lot of back pain as well. Next point, please.
Dr. Bimready, one quick thing on
Yep.
the bulging disc I want to emphasize is that bulging discs are normal. It is a normal process that happens to the disc. And so we have patients who come in with back pain, they had an MRI done, and it shows a bulging disc. That is not the smoking gun. Like that, just having a bulging disc does not mean that that's the source of your pain. And so it actually does take a lot more work to figure out the cause of your back pain, because bulging discs are normal. If you take a jelly donut and you put it on the counter, it's going to get stale. That's just what happens to the jelly donut. That doesn't mean it's a bad jelly donut. It's just what happens. So that's what happens to your discs too. They wear out, they degenerate over time, they get dry, they get crusty, and sometimes they can cause pain, but they don't always cause pain. So it's not a smoking gun.
Next point, please. Okay, disc herniation. Can you click on that again, or next, advance that? So disc herniation is where the disc actually leaves the space where it's supposed to be and protrudes into the spinal canal. Advance the slide, please. So you can see here a picture of a normal disc and a picture of a herniated disc, and the pink content is what's called nucleus pulposus, or is the main part of the disc that herniates. And when there is a defect in the ring that contains the disc material, it can slip out, and then, as you can see in the picture on the right, press on the nerve. And then you can have sciatic type of pain. And when this happens in the cervical spine, you'll have symptoms in your arms generally. Whereas if this happens in the lumbar spine, you'll have symptoms in your legs. You can also have symptoms in your legs if it happens in the cervical spine, where if it is pressing on the spinal cord itself instead of just the nerve. And we can target, or we can know which nerve is being pinched based on the location of the specific location in your leg or in your arm. So each nerve root corresponds to a specific area in the arm or the leg, and we can localize the source of your pain first based on the imaging with the MRI, and then also based on the location of your pain itself. Advance the slide, please. So muscle and ligament strain. So we have pretty big muscles in our back that help us stand straight. So if any of and the muscles are attached to the spine with ligaments and tendons. So anytime there is any damage to the tendon or the muscle itself, that can be a pretty significant source of back pain. You can pick these up pretty easily using, if you're trying to lift heavy objects with poor posture, or in general, if somebody doesn't use their back muscles as much, as very sedentary, and when they work harder, they can develop issues with strain of muscle or the tendon that can cause back pain. And with this, most of the time, rest usually helps heal up this process. And the other way to kind of combat this is through exercise, making sure your back muscles are strong and able to support your spine adequately. Advance the slide, please. So sacroiliac joint. So the very bottom of your spine, which is the sacrum, it connects to the pelvic bones and forms the sacroiliac joint. This is the foundation of our entire spine, and this is a very common cause of low back pain. As you can imagine, with the decades of stress that we place on our sacroiliac joints, it can get disrupted and cause pain. It used to be ignored in the past a lot more. I think more and more spine surgeons are aware of the sacroiliac joint as a cause of pain these days. And sometimes a sacroiliac joint pain can go down the leg also. So it can mimic a pain that's similar to a sciatic pain, like a pain from a disc herniation or pinched nerve pain. So it's very important to kind of do the workup to see if it is a sacroiliac joint that's causing the pain. Advance the slide, please. So, okay. Malalignment. Dislocation or scoliosis can cause the alignment of the spine, and that can cause back pain. Generally, when you have scoliosis, the nerves can be pinched on one side, and that can cause back pain. And also, your muscles in general are working harder for you to be standing and doing work to try to stabilize your spine when the alignment is off. That can contribute to significant back pain. Advance the slide, please. So the next is kyphosis. So scoliosis is a curvature of the spine to the side. Kyphosis is curvature of the spine forward. So if your back muscles are weak and they're not able to support keeping your spine erect and standing straight, your spine can curve forward, and that can also contribute to significant back pain. Next is spondylolisthesis. So this is slippage of one bone on another. As you can see, when that happens, your spine is out of alignment, and that can contribute to back pain by itself. It also puts extra stress on the joints in the back where that arrow is. It's putting stress on those joints, and that can contribute to back pain. And also, you can have pinched nerve, because the nerve tunnel, if you can see the top line, can you see my mouse where I'm pointing? No, okay. So if you see the top line, right above that is a nerve tunnel, right there. And then the nerve tunnel where the slippage is smaller, so it's pinching up the nerve, and that can contribute to the back pain also. The other thing that this does is it stresses the disc, and eventually the disc is gone, and then you can have a bone-on-bone from those two bones, and that can contribute to the back pain as well. Advance the slide, please. Compression fractures. So here you can see a cartoon of a compression fracture there. As we get older, our bones get weaker and we can develop osteoporosis. That's the #1 cause for these compression fractures. And the other cause is trauma also can cause this. And when somebody
Hey, Dr. Benreddy, your camera cut out. I don't know if you can hear me. I think we lost I think we lost Dr. Benreddy for a second. I'm sure his internet will catch up to us. I'll just kind of take over where he left off. So compression fractures are also very common. And what happens is there's a weakness to the bone or the bone density that causes it to not be able to withstand a load on the spine. So weaker bone, we call that osteoporosis when it's demineralized. Patients with weaker bone can get a compression fracture where a force on the bone causes the bone to collapse, and it can be very minor with just a small little squish, or it can be a much bigger fracture or compression where the bone goes from rectangular to more wedge shaped, like in the picture. And compression fractures can be very painful. Often they're associated with some kind of event. So patient says they fell and landed on their butt, or they were lifting something heavy and felt a sudden sharp pain in their back. So if you come to us with that kind of story, and maybe you're older, 70s, 80s, or postmenopausal women, they're at high risk for osteoporosis. And so we'll get an X-ray or a CAT scan or even an MRI to assess for a compression fracture. So that's a cause of an acute pain in the spine. Next slide, please. Next slide. So go back. Ankylosing spondylitis is a special condition. It's an inflammatory disease. It doesn't affect a large percent of the population, but it does affect some, and it can cause back pain. And so if you look at the picture, the disc spaces are there, but the front of the spine is actually contiguous. You can see the bone bridging across the disc space. And so ankylosing spondylitis, the spine actually fuses itself. And so these patients, they can get what's called sacroiliitis, or pain in the SI joints, or the sacroiliac joints at the base of the spine. So these patients complain of low back pain, especially in the morning. They complain of stiffness. Their spine is actually fusing. So they physically can't bend like they used to. And so that's because their spine is fusing. And this actually affects younger people. So patients in their 30s, 40s start complaining of low back pain and stiffness. That ankylosing spondylitis might be a cause. It's a rare cause, but if it doesn't get better with the typical treatments or we see the changes on imaging, then we may send you to a rheumatologist to get some blood work and some tests and see if you have ankylosing spondylitis, although it's pretty rare. Next slide, please. So there are non-spine causes of back pain as well. And so you can have arthritic hips, that the pain kind of radiates to the low back. And so whenever I check patients with low back pain, I check their hips to check the range of motion, or if I can reproduce their pain by moving their hip joint around. Piriformis syndrome, you can see in the picture, piriformis is a muscle that it's basically a butt muscle. It's a deep gluteal muscle that helps to move your hip. And piriformis syndrome, you can have pain in the piriformis from a tight piriformis, or which can cause kind of butt pain or pain in the low back. And it can even pinch a nerve. In some patients, the tendon of the piriformis is very tight, and it can put pressure on the sciatic nerve and cause sciatic nerve symptoms or pain down the leg. So the piriformis can be a cause of pain. The kidneys, right? A kidney stone can cause flank pain, right? And we see patients with back pain. It's off to the right side. It's below the ribs, off to the side, and that can actually be a kidney issue. Or so we use physical exam to help diagnose that. Next slide, please. So there are a lot of different causes of back pain. And so our job as clinicians is to try and figure out why you're having the back pain. And we do that through a variety of different ways, but often enough, the key is just talking to the patient, where we ask, where's your pain? What makes it better? What makes it worse? How long has it been there? Is it constant? Does it come and go? Did it happen all of a sudden? Has it been going on for months? All of that can help us collect information to try and make a diagnosis and ultimately help guide treatment. And so we do physical exam maneuvers as well in the clinic, where we're touching tender spots. We're stressing joints. We may test your sacroiliac joints. There are specific tests to stress that one joint to try and figure out the source of your pain. We also use imaging. So I often get X-rays on every patient who comes into my clinic. it tells you about the bones, and it tells you about the patient's alignment. The patients are standing up when they get the x-rays. So it gives you information that's different from other studies, like a CT scan, which is the image on the top left. CT scans give you a good picture of the bone. And so if you might see a compression fracture, you'll see arthritic changes. MRI gives us a good picture of the nerves and the discs, the non-bony structures. So we may get an MRI if we think there may be a cause of your pain that's not related to the bones themselves. And then there are nerve tests that we do as well. We send you off to a neurologist or a physiatrist to get an EMG or a nerve conduction test. Those are the providers that perform that test. But basically, they're testing the nerves and how the electrical signals travel through your nerves, and that can tell us if you have a pinched nerve in your back versus a pinched nerve in your leg or something like piriformis syndrome. So an EMG is also helpful in making a diagnosis. Next slide, please. And so imaging, at least in my practice, I always start with x-rays. They're cheap, they're easy, they aren't a ton of radiation like a CAT scan. So not everybody needs an x-ray, but if you're coming to me as a spine surgeon, I want to see your spine. So I often get an x-ray. It shows me the degenerative changes. It shows me the height of the discs, whether there's a lot of disc wear. It shows me the alignment. And it can also clue me into bone density problems as well. If the x-ray doesn't tell us what I need, tell us what we need to see, then we may order other studies like an MRI. Typically, an MRI is reserved for patients who have tried conservative management and haven't gotten better, or we're looking for something specific like a pinched nerve, or if we're concerned about like a tumor or infection, then an MRI becomes very useful in that population. We have to be careful getting MRIs on everybody. One, they're very expensive, especially if you have to pay out of pocket. We're talking thousands of dollars, so it's very expensive on the medical system. So, and not everybody needs it. Most patients get better. Remember our first couple slides. Most patients get better in the first few weeks. So getting an MRI right away is a waste. Also, it can show us things that you don't want to see. So the little degenerative changes like the bulging discs or some wearing away of the disc or some arthritis in the joints, the MRI is going to show us that, and that can be a source of anxiety for patients because they see problems with their spine when in reality the problem is not in their spine, or it's not not that problem. So an MRI we use in specific indications. Just because you come to our clinic with back pain doesn't mean we're going to order an MRI right away, because it may actually not be beneficial to you at all. Next slide, please. Dr. Bimretti, you're up. Is your
Yep.
computer working?
Yeah.
Great.
Can you hear me? Yep.
Yeah, we got you.
Okay. So the treatment options for mechanical low back pain. Now, keep in mind this is in the back, not necessarily going down your legs or anything like that. So first, probably the first things that we can start with is diet, exercise, weight control. So we talked about some of the causes of low back pain, where being excessively overweight can cause back pain because it stresses your spine. So making diet changes, exercising more regularly to lose the weight, or even in some instances having a referral to a weight management doctor or a bariatric surgeon may be the first line of treatment for the back pain. Also, cessation of smoking. As Dr. Quinones mentioned, nicotine itself alters the perception of pain in a lot of people. So by quitting smoking, you don't have the nicotine in your system. That may help with your pain as well. Then physical therapy. Physical therapy is extremely valuable. They will work with you to increase the range of motion of your muscles. So if you have any muscle tightness, they'll work with you to try to loosen up those muscles, and also give you exercises that strengthen your back muscles, so you're using them more efficiently in supporting your spine, and thereby decreasing your back pain. Medications, some of the over-the-counter medications such as Tylenol and Advil and Aleve, which are NSAIDs. They are very powerful, very good medications that help a lot with back pain. Then we can talk about muscle relaxers, which generally you need a prescription for it from either a family doctor, or if you see a spine surgeon or a spine specialist. Muscle relaxers may help loosen up those muscles and help with the back pain. And a steroid taper. So steroids just decrease inflammation in the body, and some of the inflammation that causes back pain is affected by the steroids, and that those may help with your back pain as well. Then spinal injections. So injections can serve as two different purposes. One is to treat the pain, and also to diagnose the pain. So if you have a disc herniation that's pressing on a particular nerve, you can target that particular nerve to get an injection of steroid medication and a numbing medication, which if it works, great, your pain is controlled, but it also gives us information that, okay, that is what's causing your pain. Now, if you get the injection and you don't have any relief or any pain relief, especially when we use targeted injections, then maybe that's not what's causing your pain, and we have to do more work to evaluate and see what's the cause of the pain is. Now, these injections could be targeting the nerve roots. It can target the nerves, the medial branch nerve that supplies the joints in the spine. Or these injections can also target the piriformis muscle and also the sacroiliac joints as well. And the last option, and the most invasive option, is surgery. And surgery is usually reserved for where we can identify a particular source of back pain. So if we see somebody has normal appearing spine on imaging and they have back pain, then won't necessarily be a candidate for spine surgery, because there isn't something that I can see that I can target, fix surgically. A lot of times, if you have a herniated disc that's causing a pinched nerve, or an arthritic change in your spine that's causing a pinched nerve, then and your pain correlates with that nerve, then we can target that particular nerve and do what needs to be done to remove or alleviate the pinched nerve, and that can help with pain symptoms. But if during our workup, we, as I mentioned during one of the earlier slides, where there are numerous joints in the spine, and we target one joint, one particular level, you could have arthritic changes at a different joint that are minor, that could be contributing to back pain also. So that could affect the success of spine surgery. Now, going up there, looking at the physical therapy for as a treatment for mechanical low back pain, some people will go to chiropractors to help with the low back pain, particular low back pain. I think it's something that you can try doing that, especially for low back pain. And some people will find success with it, and some people won't find success with it, like any physical therapy.
Hey, Elise, go to the next slide. There's a big list that includes chiropractics, and there are a lot of other treatment options, which Dr. Bimretti mentioned. I know we're running out of time soon for questions. I just kind of want to get to the question answer session so you guys can ask questions. But this is a list right there, and it's not exhaustive. There are a lot of different treatments for back pain. So if it's something you want to you feel you need treatment for back pain, come and see us at the Premier Health Spine Center, because we use all of these treatment options. We have specialists that do a variety of these different treatments. And so the Premier Health Spine Center, you know, it covers everything. We you know, it's cliche, but we've got your back. So here's this is a non-exhaustive list of treatment options. Can you go to the next slide, Elise? And so really we know it's back pain is common and it can come and go. And so how do you keep it from coming back? One is maintain a healthy body weight, right? Less pressure on your joints, less pressure on your discs, and less work for your muscles to have to stand you upright. So maintaining a healthy body weight is critical, and it's actually one of the simplest ways to protect your back and prevent low back pain. Not always easy to maintain a healthy body weight, not in today's society, but it is definitely worth it because it plays a big role. Keep a strong core. That means work your abs, your back, your butt, your hips. All of those muscles help to stabilize the spine. And so working on core stabilization is important. Like we said multiple times, don't smoke, don't use nicotine. That will help prevent back pain. Using good posture, body mechanics, make sure you're lifting, you know, if you're lifting off the ground, you're bending your knees. Try a standing desk, be conscious of your posture. Those can help prevent low back pain. And just get out and exercise and try to not sit on the couch all day and watch TV, you know, have a hobby that gets you outside, walking, physical activity. All of that's going to help prevent low back pain. So Elise, can you go on to the next one? And so let's do some questions. Elise, I think you're up.
Okay. Actually, I think you answered a few of them towards the end of the presentation. We had a couple questions around chiropractic care and your recommendation around that, as well as physical therapy. If there's anything else either of you want to add, we did have a couple questions around both of those things.
Dr. Benready, you have anything?
Yeah. So chiropractic care, you can try it. And I have had patients that have really good results from it. I have had patients that it helps very temporarily, and then the pain returns. But it's something that you can try. Usually, at least for the low back, low risk, and it's not very invasive often. So definitely can try chiropractic also along with physical therapy.
Yeah, and I worry about manipulations in the neck. Of chiropractics, you know, inline traction is great, but I really don't like them manipulating the neck. I have seen patients who have been injured by that pretty severely, but the low back and mid back is very safe. So the downside of chiropractics is that most insurances don't usually cover it. And it's kind of like massage. It feels good when you have it done, but you live on Earth, there's gravity. And so the results can be kind of temporary. Now, physical therapy is different, right? Massage and chiropractics is somebody doing something to you. And that's why the relief is temporary. When you get into physical therapy, the therapist is going to teach you what to do on your own. And you do them at home, and you do them for the rest of your life even. And that's what keeps the back pain away for long periods of time. So that's why I really like physical therapy, because it's an active treatment. It's you doing something, and that results in more long-term results or relief.
Yeah, and also another thing with physical therapy, when you start that, is typically you are putting a lot more effort into it. So some patients will come back, after 1 or 2 sessions and say their pain is worse. But if they stick with it, then usually the pain will get better. But the first couple sessions, if your body is not used to those type of movements and you're actually putting the work in yourself, you can be in more pain, at least the first couple of sessions, than what you were prior.
Okay, the next question is, my husband has Parkinson's and has terrible posture and struggles with back discomfort. He does Parkinson's therapy and also has in-home therapy. Is there anything else we can do?
Yeah, absolutely. Parkinson's is a tough disease, and it can affect the spine, but even more so, I often see it because these patients have postural problems. And the reason is the underlying chemical issues that Parkinson's causes in the brain. And so patients who with Parkinson's, they have a stoop posture, slow gait, shuffling steps, and that can cause back pain. And so if you optimize the Parkinson's treatment, their posture improves. Their back pain can improve because of that. And so I would actually recommend you talk to your Parkinson's doctor, or get hooked up with our Clinical Neuroscience Institute. Even like a deep brain stimulator. I've seen patients who they come to me, they have big bad back problems, stooped posture, they would need a big fusion to stand them up straight. And you send them to the neurosurgeons that do deep brain stimulation, they get the probes in, and they're standing up straight. So I would actually optimize your Parkinson's treatment, will actually help the back pain probably more than anything else.
Yeah, I agree with Dr. Quinones. Maximizing that treatment is first and foremost, because that if not, nothing we as spine surgeons do is going to prevent those issues from happening further, even after we do any treatment, any surgery or anything like that we do. Those issues are going to continue, especially affecting your muscles. So optimal treatment for the Parkinson's is really important.
Okay, our next question is, once you have spine fusion surgery, what is the probability that you will have to have further fusion at other levels of your spine?
Yeah, so it's very common to hear that people have had one spinal fusion and they continue to have more and more surgery. The reason behind that is when you fuse one segment of the spine, you're distributing the stress that's taken up by that level to the next level, and eventually the arthritic changes at those levels will increase to the point where you might need surgery. So in the neck surgery, it's about 2% a year, or about 20% in 10 years, you might need further surgeries. In the back, it's probably between 10 and 20% also in 10 years that you might need more surgeries at the adjacent segments. So in a young person, if you have a fusion surgery, then based on life expectancies, it's very possible or highly probable that they will end up with multiple fusions in the future.
Just to expound on that, yes, old spine surgery was a big problem where patients were getting a fusion and then the next level would degenerate rapidly and they'd get another fusion, and they would just have fusion after fusion and they would march up their spine. That's old spine surgery. Their newer spine surgery really focuses on alignment of the spine. When we align your spine appropriately, then it actually reduces your chances of needing further surgery. So if you have the lumbar spine has a curve to it called lordosis. If we don't give you enough lordosis, you have a 10 times higher risk of needing another surgery at the next level. And so we can help prevent that kind of marching up the spine phenomenon by doing good surgery the first time, by restoring the alignment appropriately. And that can really protect you from needing more surgery in the future. It's really easy to fall into the trap of, oh, this surgeon's going to do minimally invasive MIS. It's going to be done with a robot. It's going to be real fancy. It's going to be cute. I'm going to go home the same day. But if they don't talk to you about alignment and how they're going to restore that normal curve, then you should run away, because you are at risk, 10 times higher risk of needing another surgery.
Our next question is, does water exercise help?
Yeah. Yeah, so the water exercise is very, very helpful. I always recommend it when it's mainly mechanical back pain. As we talked about, the body weight is a big cause or contributor to back pain. So when people get in the water, that the weight is eliminated. Gravity is eliminated or decreased from the equation. So you're able to work your muscles, and taking the weight off the body can help with the with back pain. You're able to work a little bit harder and more efficiently use your muscles in water. So it does help.
Yeah, absolutely. And you don't need to know how to swim. You just stay in the shallow end and hold onto the wall. But it is a great exercise if you have access to a pool. And I highly recommend aqua therapy or water exercises if you can get into it.
Okay, can you describe the treatment for spinal compression fractures, which you discussed? My wife has osteoporosis and has had 2 of those, and the relief was almost immediate.
Dr. Bimretti, do you do many kyphoplasties?
Yeah, I will do them, but you're very patient. You usually recommend treatment with the brace first, and because studies have shown that about a year, 2 years down the road, people that have been treated with kyphoplasty are putting cement into the compression fracture bone, versus people that haven't had any procedure done. They have similar pain relief. The pain relief with the procedure is usually faster, but with time, usually the pain level kind of equalizes. So I'll maximize non-operative management, non-invasive management with bracing and pain medication, and give the chance, the patient a chance for the pain to improve. But if it is not improving, then we can do a procedure called kyphoplasty, where we put in a balloon and restore some of that alignment or the normal shape of the bone, and then put cement in there to hold everything in place. There's also a procedure called vertebroplasty, where you put in cement. You don't really restore the height of the vertebral body, but another procedure also as an option for osteoporosis. And then also I recommend following up or getting treated for the osteoporosis itself. That's the best treatment to prevent future fractures.
Yeah, I actually have a very similar philosophy for compression fractures. Kyphoplasty definitely works. It can relieve pain from a compression fracture, but not everybody needs one. So patients who have really severe pain that brought them to the hospital, or they're not able to get around, those patients benefit from the kyphoplasty early. Some patients, we treat them non-surgically in a brace. They don't get better right away or over the next several weeks. If they're still hurting, we can do the kyphoplasty and help them. But I don't do a kyphoplasty on every patient, because the vast majority of patients get better on their own. And the kyphoplasty itself has risks. You have a 27% increased risk of having another compression fracture next to a kyphoplasty. So I don't do it for everyone. I only do it for the patients that really need it. But yes, it is a viable treatment option and does relieve pain.
So I have one more question, so I'll make this kind of our last call for questions. The question is, I had a C-section and a spinal, and now I'm really feeling pain in my lower back. What can help?
Yeah, this is I see this quite often, and it kind of it's a tough situation, because the question is, did the spinal actually cause scar tissue or sensitization of the nerves, and that's why you're having the back pain? Or are you having the back pain that everybody else gets that didn't have a spinal? So the question is it the spinal that caused the back pain? And if it did, it's probably related to scar tissue or touching one of the nerves, their nerves to the muscle, nerves to the joints. And could there be a local nerve injury or scar tissue? We don't really know, and it wouldn't show up on an imaging study. Like an MRI wouldn't really show that scar tissue or injured nerve. So we often don't know the exact cause of the back pain in that situation. We tend to treat it the same way as we do other forms of back pain. And I would say that one option in that story or that situation that I would try on a patient if the typical treatments don't work is I would try what's called desensitization training, where I send you to one of our physical therapists who's trained in this, and they basically work with you on desensitizing the skin and the tissues in that region of the spine where the needle went in and you're having pain. So that's one additional treatment option that's specific to that possible cause of low back pain.
Okay, well, thank you to both of our panelists for your very informative presentation. We really appreciate your time and expertise this evening. And I want to thank you all so much for joining us. I hope that you found the information that was shared very useful. We're very privileged to be with you tonight and hope you consider us for any healthcare needs that you may have in the future. More information about our panelists and their practices was included along with the information to access tonight's event. If you have any additional questions or would like to make an appointment, their office phone numbers can be found there. And last but not least, just a reminder that this seminar was recorded. We will email you a link to the recording later in about a few days, should you want to go back and listen to some of this content again. Along with the recording, in that same email, we will share a link for a short survey on tonight's program. We very much value your feedback and would appreciate if you could take a few minutes to share your thoughts with us. And with that, thank you again, Dr. Quinones, Dr. Bimaretti. We wish you all a good evening and thanks so much for joining us this evening.
Thanks. Have a good
Thanks
night.
for having me. Good night.